I want to say good morning to everybody, and first of all, to thank Armine for the wonderful introduction. And actually, the introductory remarks captured in about 2 minutes the essence of what I'm going to say in about 25 minutes, so bear with me as we plow through this. But Armine does a wonderful job as a national spokesperson, international actually in many ways, for the Center of Policy Alternatives. I hear her on CBC regularly and on national television, and it's great that they're participating and Armine is here. Thank you very much for coming to Saskatchewan, and thanks to all of you. I see many familiar faces. I'm not now going to get into the habit of identifying too many because I'll miss somebody, but thanks for showing up for what I think is a very important seminar that you're having today. It's an honor and a pleasure, therefore, for me to be invited, and I want to thank all of the sponsors, the three major organizations, for inviting me to spend some time with you today. Now, as Armine has pointed out, today's gathering is especially timely. In a few days, on July 1st, we'll be celebrating the 50th anniversary of the introduction of Medicare in Saskatchewan. The first jurisdiction, need I remind anybody here, in North America to adopt a program of universal health care. I was saying to Dr. Albritton as we were watching the slide and listening to Armine, I shared many a platform with Tommy as a young student in what was a very acrimonious debate. I'll say a few words about that in a moment. But milestones such as the 50th anniversary of Medicare allow us to, as Armine has pointed out, to reflect upon some hard-fought accomplishments of the past, and perhaps even more importantly, certainly at the same time, to reevaluate the future. Today's Medicare, the debate about it and where it should go and where it is going. After all, the lessons of the past are often the guideposts to the future, as they say. As we know, the achievement of universal health care took a long, acrimonious, and very protracted road. But it's no surprise, in my judgment, that this province was at the forefront of Medicare. After all, our citizens learned many hard lessons during the desperation of the Great Depression and the sacrifices of the Second World War. We learned about generosity, about hardship and fairness, cooperation, about boom and bust, and the imperative for cooperative action. Emerging from the tempest of those tumultuous times, they sought a new direction in how public services would be organized, a direction based upon community action and cooperation. I think a brief review, very quick overview of the 50th anniversary might be in order. Tommy and 46 of his MLAs were elected by the Saskatchewan voters in 1944 with a major mandate for major change. And one of the most important changes Douglas sought was the way in which health care was to be delivered. It was a very early and perhaps central dream of the many visions and dreams that he had about the province and the future of Canada. As we know, the traditional template was based on the private for-profit model. Patients paid for the services of medical professionals and hospitals, and often those who could not afford health care, as we know, did not receive it, and even some who could, well, they deferred their treatment, hoping to save their resources. I was a very young boy, and I remember very well those periods. My father was a laborer, a section man for the Canadian National Railways. Being an immigrant from Ukraine, became a new Canadian. We lived very, very modestly on the west side of Saskatoon, and there were those occasions when homemade medicines were the treatment and the order of the day rather than going to see the doctor. Dr. Albritton might say sometimes those work better than actually going to the full-time medical profession, but nonetheless, I had that taste, and I'm sure many of you, as I look around this room, have also experienced the same. Douglas's philosophy and vision was completely opposite to this tradition and history. Simply stated, healthcare was not, in his judgment, a market commodity, but a universal and basic human right that respected the dignity of the individual and promoted the welfare of the overall community. In the belief that at the greatest time of need, when we're ill, all of the community rallies to the support of those who are in need. Money should never be the barrier to the provision of needed health services. In 1994, when he was elected, however, the nation was preoccupied with its economic and fiscal recovery and the preparation of the return of soldiers back to the homeland. Here in Saskatchewan, we were essentially broke. In fact, we were broke. I knew a little bit about that in 1991, but in 1944 it was serious. And believing in the imperative that governments must act in a fiscally responsible way, which was, by the way, one of the fundamental principles of Douglas, the burning desire to implement universal Medicare was delayed. But not all such initiatives fell into this category of delay. For example, in 1946, the Saskatchewan Hospitalization Act, the very first program of its kind, was enacted in Saskatchewan as one of Douglas's first major policies. Later to be made eventually, as we know, a national program under the leadership of John Diefenbaker's government between 1957 and 1961. In Saskatchewan, even though the finances were a major obstacle, nonetheless, the engine rooms deep in the bowels of government, key officials and advisors were meticulously planning to extend universal coverage beyond hospital care to medical care insurance when the time came. Well, eventually the economy recovered and the province's finances benefited as well from the federal government cost sharing of hospital insurance, an example, by the way, in that cost sharing of cooperative federalism, something to which Armine alluded, we are not now experiencing. It's confrontational federalism. I'll say a word about that. So after winning the re-election in 1960 on a platform, and it was a specifically fought platform on implementing Medicare, Douglas moved with the introduction of the Saskatchewan Medical Care Insurance Act of 1961. But we also know that Douglas at the same time was about to transit from Saskatchewan and to assume the leadership of the newly formed New Democratic Party, where he played the leadership role as the first leader. He was succeeded by Premier Woodrow Lloyd, who had the very, very difficult passage of steering this bill through very tumultuous times. And believe me, they were tumultuous. I was on campus in those days as president of the Students' Representative Council, and a good friend of mine by the name of Don Moloshin, who's passed away, unfortunately, we were so taken by the cause that Douglas and Lloyd in particular were fighting in the midst of a strike, in the midst of the upheaval, social upheaval, that we climbed into Don's Volkswagen Beetle and somehow made it down to Regina, totally unannounced, to offer our support to see what could happen. There wasn't very much we could do. They would say, here, go to this rally or do this file, deliver it from one office to the other office. I remember being at one rally in the evening, which was headed by the KOD, the acronym for Keep Our Doctors Committee. And I won't get into the details of it all, but to give you a flavor of how the atmosphere was so poisoned and very hostile, the guest speaker was a member of the cloth who took off his cleric's garb because he was speaking not as a member of the clergy, but as a concerned citizen of Canada and worried about communism. And then the speech just flowed out in all of its flourish to a jam-packed room. And how he knew that the room was full of communists too, because he could feel them with his elbow. And they had to be, we were there in the room at the time, so you can imagine that I didn't know whether it was an honor or something that we should fear being called a communist. I don't think I was ever been called a communist, right, Stephen? Whatever else I've been named. But it was a very, very emotional period. And I remember in those days, just to finish off without rambling and taking up too much time, Woodrow's home actually was guarded at both ends of the street by police cars. There were so many threats on his life at that particular moment. To my thinking, Woodrow Lloyd steered not only this very difficult passage of the bill into law and got it implemented. By the way, later I served as assistant commissioner on hospital privileges because once the strike ended, the next fallback action by the doctors was that they wouldn't allow the UK doctors hospital privileges. Why? Because they didn't take a 3-month rotating internship in obstetrics, if you can believe that. So a Royal Commission was set, and I was the assistant secretary on that commission job. But my point that I really want to say is that it was tumultuous times, very difficult times, and Woodrow Lloyd remains an unsung hero, a great unsung hero of Medicare in Saskatchewan and Canada, and deserves recognition to that effect. Well, like most great historical achievements, as this story has told you already, it was not one without a major struggle. A bitter and divisive doctor strike of 23 days paralyzed the province, claiming that the Medical Care Insurance Act would destroy the so-called sacred relationship between doctors and patients. All but a handful of brave Saskatchewan doctors withdrew their services, maintaining only emergency care at certain hospitals. They were strongly supported by the business community, the Keep Our Doctors, KOD group, of which I've referred, that sprang up in numerous communities. And I have to tell you, the entire media, both in the province and not completely outside, but largely outside, were opposed to what was taking place. Fortunately, however, the goal of Medicare was still supported by the majority of Saskatchewan people and Canadians, as it turns out, and this gave strength to Lloyd and the government in its darkest hour. In response to all of this, the Lloyd government recruited doctors from the United Kingdom to provide services to the public after the doctors went on strike. And they were working out the regulatory means to bring sympathetic doctors from the United States as well. John and Betsy Berry will tell us a word about the development, and John's contribution himself to the development of this particular important factor in breaking the doctor's strike. And eventually it was broken. As the strike wore on, Lloyd asked help from Lord Taylor, a key architect of the UK National's healthcare service. Taylor came over from the UK, acted as mediator between the doctors and the government, and eventually a difficult, not perfect, but difficult compromise was struck that ended the dispute, and one that would pave the way for Medicare's implementation throughout all of Canada. And it was eventually throughout all of Canada. Here, Emmett Hall's leadership, another Saskatchewan boy, followed by Tommy Douglas's constant efforts to keep Medicare before the people and Parliament, and finally Lester Pearson's decision to implement national Medicare, that we achieved our goal of universal medical care for the people of Canada and Saskatchewan. One lesson out of all this story: no great change is achieved easily. It always comes with a great contest, and we should be prepared for that and be mindful of that as we look forward to the challenges facing the Reformation and the sustenance of the future of healthcare. So I recite this brief overview because we're meeting on the eve of the 50th anniversary, excuse me, and to remember the courageous leadership of those who preceded us, and to emphasize yet again that Medicare, as Armine alluded, reflects a fundamental value of Canadians. We value compassion and active support for those of whom fate has dealt a difficult hand, through illness or through accident. As Canadians, we believe there are some fundamental issues which can best be overcome by the positive actions of the community working together. So, as briefly described, that was the first battle for Medicare. There have been many skirmishes since, and regrettably, it is all but certain that there are yet to be many more major skirmishes to come. As we look at the state of the contemporary debate in Canada, it's clear that those same two visions, fundamentally competing visions, seek to shape the next stage of the debate. One view, based on the premise that healthcare is a commodity to be bought and sold in the markets, and it should determine who gets care, when, and how. That's the alternative vision. The other, and if you still have any doubt about the one that I adhere to, believes that healthcare is a public good. It's grounded on Canadian values of fairness, equity, compassion, and collective action. And as Armine pointed out in my final report as Royal Commissioner, I took the view that Canadians view Medicare as a moral enterprise, not a business venture, that it is a right of citizenship, not a privilege of status or wealth. Keeping this foregoing in mind, this morning I wish to focus on the current environment, more specifically surrounding the current healthcare debate. To place it in full context, I want to continue with just a few more thoughts about values, because the choices we make will tell us about our nation's values and its future. Every day, Canada faces new challenges that ask key questions about what kind of people we are and what kind of future we wish to shape. Today, we're talking about discussing the delivery of health care, envisioning the future of Medicare. But we could just as easily be discussing the integrity of our environment or our domestic choices with respect to social policies and economic programs, the role of working men and women, the role of unions in our society. In confronting these and other important questions, we should never act as if we're starting from scratch. In fact, the exact opposite is the truth. Every nation has a narrative, and Canada's history and narrative offers a strong and rich legacy of success that has forged our country. It's a legacy that I call a shared destiny, a key to determining and understanding our young and yet dynamic history as a nation. And it's the same legacy of shared destiny that, I would argue, remains the roadmap for our future at home and abroad, and especially when it comes to the future of Medicare. As I suggested in my opening remarks, for those of us like me who came of age in our prairie communities or know our history, the notion of shared destiny is key to our existence. Here in Saskatchewan, the harsh, often snow-blown conditions, droughts, distance and isolation, and small population forced us together, kind of like poplar trees, huddled together on a wind-swept prairie plain. And so it is with other regions in Canada too, which have their history, where geography and demographics may vary, but where, as Canadians, I would argue, overall, we all learned to see survival and progress as a test of our ongoing ability to organize ourselves collectively and to remain united around those shared values and those that shaped us. And so through the years, as we lived together, worked together, and built together, this notion of shared destiny has been transformed, I argue, into the very foundation of what is called Canada, a great nation. Generation after generation of Canadians have seized on the cornerstone that our future and our society is frequently best shaped through community action, that the sum of Canada is often greater than its remarkably diverse parts. This then, as I see it, is our nation's narrative, and it resides in our collective DNA. But as I've said, in recent years, the soil has been tilled for the sprouting of views and values at odds with this narrative. Today, there's a palpable momentum toward individualism, decentralization, privatization. It's the year of the rugged individual again. And Medicare's future is now caught up in this so-called new thinking. And just like with today's many other issues, how we choose to inform our way forward and the set of values that we draw upon to shape our progress will ultimately become an expression of who we are as a nation and who we are as Canadians. That is why, in my view, the debate over Medicare is not just about effectiveness and efficiency, as important as those are. It is not simply about the irrefutable evidence showing our single-payer public system delivers excellent outcomes, which it does. The Medicare debate is not even about basic Canadian values like equity and fairness for all citizens. Yes, it is about all these things, but it's also about much more. Medicare holds such a central role in our national fabric and our national narrative that how we reform it and how our social programs and the reforms that are required to them are made will determine the future progress and the future nature of our country, or whether in fact we do make any progress at all. That's how important I view this debate. So keeping this in mind, what is the road to the progress for the future of Medicare? What should we envision? Well, the good news is that there are solutions readily at hand, ready to be seized by our policymakers just as soon as they gather the political will to act. Shortly, you will hear from many people with informed comment and discussions about those solutions. who know and who will be participating in this event on their views regarding these changes. Let me explain, however, 5 enduring lessons, large lessons, that I believe remain central to whatever the programs look like and how they're reshaped in the future. These 5 are as follows. First, we should remember the single-payer advantage. My first point is that a single universal payer public insurance model is both less costly and produces better population health outcomes than multi-payer systems like other countries have, most notably the United States of America. This has been proven time and time again by study after study after study. Let me illustrate using the example of pharmaceuticals, which for most Canadians are currently outside of our public insurance system. Since 1990, the cost of prescription drugs given to us by doctors, prescribed to us by doctors, the cost of prescription drugs as a percentage of total health care expenditures has increased from approximately 8% to over 15%. I could be wrong by a fraction here or two, but that shows you more than doubled. Canada's private spending, private, not public, spending on prescription drug now outpaces that of most of the other OECD countries because it's outside of the single-payer system. If you're in hospital, it's covered. The moment you're discharged and you still have the medication, it's not covered. Our task is clear, if not without difficulties. We must lay the groundwork now for including catastrophic drug costs, at very least, and bringing other aspects of reform such as home care, long-term care, access to advanced diagnostics, the areas of rising costs in the fastest fields, all within the umbrella of a more coordinated and more unified system of delivery and public funding. There are other reforms as well. If we don't, costs will continue to escalate without restraint and with relentless abandonment of those in need, violating the values of which I've alluded to at the beginning, and with it will be the increasing and growing call, as we're hearing now, about more efficiency, the excessive cost of health care, that we can't afford it, and therefore we should go to something called private health care with an entirely different set of values, as I described by the historic battle that Douglas had and that many of us, I hope, believe here in this room. So the first advantage is the single-payer advantage, and we should strengthen it and improve on that. Secondly, keep the focus on total costs. Here my second point is that our focus on controlling healthcare costs should be on the total costs. We must avoid shuffling expenditures between public and private sectors of the healthcare system. Until the mid-1990s, some provincial governments, including my own, were successful, as Armine alluded, in restraining the growth of public health care costs. This is a bit of apologia, but it's true. I never dreamed after all my years in political life that if the opportunity came to become premier, that I would find myself in the position that I did in 1990-91. It is no overstatement to say the province was dead, flat, broke. We were paying BBB ratings of costs, couldn't borrow money, and that was the lot in life that I was dealt. Mindful of Douglas's motto also, you have to make a choice about whether the bankers decide what you do or whether you decide what you do. And if you want to decide what you do, you got to control your finances. As I say, this is not by way of apologia, that was the circumstance we inherited. Peter Preble will know all about this. So we rationalized our services as carefully as we could without hurting too many people. I'm sure we did, though, hurt people. We worked to improve efficiencies while trying to preserve access to quality services. As I say, the fiscal position obligated us to this point. But my point is keeping the focus on total costs. And as I look back at it now, it may just have turned out that in doing all of this, what we really did is we pushed some of these important costs and programs out of our own provincial government budgets and right into the personal pockets and personal budgets of you and me and individual households. In the end, this is false economy. The total bill for health care is at issue. Whether we pay out of one pocket through the taxation system to government, or out of the other pocket to private insurance companies, or pay over the counter, it's the total costs which count. We seem to forget total costs in this discussion, and we should always keep those in mind in fashioning the changes which are required. But back to my first point, every indicator demonstrates that the public health care system delivers outcomes at the best rate and at lower costs. Dollar for dollar, Medicare brings you the best bang for the buck than any other form, such as a blended private-public system or a private system. Third, tackling wait times. This is controversial. I'm looking forward to what Stephen Lewis and others will have to say about this. But I know that we keep on hearing the mantra about improving timely access to quality services. And while the vast majority of Canadians who have used the system find it highly satisfactory, according to all the opinion polls, there continues to be a significant proportion who argue that they wait an unacceptably long time for care. Now, Canada's policy responses, most specifically the one again that Armine alluded to in 2004, the so-called Fix for a Generation, tried to deal with this question of wait times, but did so in a very misplaced way. Now, I'll just tell you the essence of my report very briefly. The original Medicare deal was 50 cents out of every dollar spent for Medicare would come from Ottawa. 50 cents would come from the provinces. In fact, that's what Pearson used as the hook to get Alberta and Ontario and Quebec to join Medicare. Instead of paying $1 out of their own taxation regime and from their own residents, he would offer 50 cents on the dollar on a cost-shared program, but, capital B, capital U, capital T, but the condition that was attached was those provinces had to accept Saskatchewan-style Medicare. Conditionality. Over the years, including through the Trudeau years, the 50-cent portion of the federal funding of Medicare dropped to about, I'm guessing, 36, 38 cents, I'm going by memory now, which meant that the cost shifted over to the provinces, or if it didn't shift to the provinces, it shifted over to you individuals. And so my main theme in the report, building on values, was let's restore the 50-50 partnership, cooperative federalism, that's how Canada works, and let's take the Pearson model by saying that by pumping it back up to 50 cents, we're going to demand some changes, long-term changes, one of which is looking at this question of primary health care, nurse practitioners, home care, long-term care, how you model the delivery of health care systems at the community clinic level. Make conditions like that, even pharmacare, a part of the 50 cents extra that you're going to get. This, the federal government totally missed. Instead, they concentrated, all governments, on 5 specific areas of care, and there are wait time areas. We now know that these 5 policy responses were completely incomplete, and they reverberated negatively on other important demands on the dollar and on timelines, and it was lacking, most importantly, a comprehensive strategy. Here are a couple of things we could do. We could carefully and thoughtfully advance more into advanced diagnostic services, although great progress is being made here, and efficient information services. We could also increase the supply of skilled healthcare providers to alleviate unnecessary blockages, and do so by providing impetus for a more integrated approach to healthcare delivery, as I alluded, remains one of our biggest impediments to reform. These have been advanced by noted scholars in this field. There is still much to do to make the current system much more responsive, much more efficient and sustainable, and other speakers and their envisioning how to do this will be very important in today's seminar. But my point here is that we should be looking at tackling the reform in an overall way as part of dealing with wait times. Fourth, and this also Armine talked about briefly, addressing the determinants of health. Here our university, Dean Albritton, has made a great contribution. We simply have to pay more attention to preventing illness and disease, especially chronic disease, which arguably is the greatest health challenge of the 21st century. The Canada Health Act, which sets out the principles of Medicare, states that the primary objective of Canadian healthcare policy is, quote, to protect, promote, and restore the physical and mental well-being of residents of Canada, end quote. Yet we continue in this country to focus on restoring well-being while largely ignoring the promotion and the protection of well-being, namely after we're ill. What about the upstream care? There are several important pathways to achieving a healthier nation. Removing the financial barriers to acute care, what Douglas called once the first stage of Medicare, we can rightly celebrate this year that great achievement. But as many of you will know, Douglas's full vision included an even more critical second stage of Medicare, as he described it, one that he lamented he did not succeed in accomplishing. A second stage that would tackle the fundamental barriers to good health, which included the social, economic, and environmental determinants, the upstream factors, before we get ill. And that's something we have yet to achieve. I tried it, by the way, in reorganizing the hospitals in that financial crunch in the 1990s and trying to convert them into wellness centers. It didn't work out. But however the model is, we've got to work on this and persistently and continually work on it. Over the past several years, several of us have been working on a little project which would highlight perhaps the importance of this particular project. It's called the Canadian Index of Wellbeing, CIW. It's housed, at least for the time being, Dean Albritton at the University of Waterloo. And I think that we can capitalize there on the work that is being done. We're very fortunate to be associated, however, with the University of Saskatchewan and a strong team of researchers led by Nazim Muharjireen, who's here in the audience, and many others here and across Canada. There's a growing community dedicated to the upstream reforms that are necessary. And by the way, Ryan Miley, while I'm name dropping here, has written a very interesting book on this particular topic, and I urge you to get a copy of it. But what is the overall goal? The overall goal is to redefine well-being as the presence of the highest possible quality of life in its full breadth of expression, to track and report on where we're making progress and where we're falling behind, to identify policy changes that will ensure that Canadians enjoy the best possible well-being, and to empower Canadians to advocate for change and to hold their leaders accountable to it. Underlying all of this is a recognition that the well-being of a nation is about so much more than its economic production. The oft-quoted, infamous or famous GDP numbers that tend to dominate our news. GDP is up 3%, and we think right away, wow, things are really good. Yeah, we may have had a storm down in Missouri or Minnesota or in northern Canada, and the GDP went up because of all the wreckage which was caused. Doesn't mean that it translates to things being better. GDP is about whether we have jobs or not. It's important, but it's also about whether the jobs are, it's not about whether jobs are meaningful and well-paying. It's not about whether they're precarious or on minimum wage. What the CIW, the index, is about is to talk about these issues and also others, like whether or not we have adequate and safe housing, supportive communities, or do we have substandard and unsafe housing in crime-filled neighborhoods. And one of the great accomplishments of Saskatoon, if you haven't seen it, is what's going on the west side there, led by our university and the College of Medicine and the dean and many of his students. It's about whether we have enough leisure time, the index of well-being, to engage with our friends and families in recreation and cultural activities. It's about whether our environment is clean, green, and sustainable, or whether it's polluted and toxic with rapidly vanishing natural resources. It's about whether or not our kids are given quality early learning opportunities and a chance to reach their full potential in a rapidly changing world. It's about whether we're able to engage in a democratic society, a truly democratic society, and fully participate in determining the directions that shape our lives, or whether we're marginalized by virtue of being poor, disabled, being an immigrant, a racialized minority, young, female, or any of the other characteristics in an unequal society that can push one to the sidelines. Friends, in short, upstream care is about the kind of world we're creating for ourselves and future generations, and whether we're progressing forward and doing so together. So in this work of the Index of Wellbeing, we've finally gotten to the point where we released our first composite index. It's going to be at the other end of the teeter-totter. One end of the teeter-totter is the GDP. We want to put at the other end of the teeter-totter the Index of Wellbeing. And we found in tracking 64 indicators in 8 categories that over a 15-year period the following. Canada's GDP grew by a robust 31%. Our quality of life on these 64 indicators in 8 categories improved by just over 10%. A huge disparity. There wasn't a single well-being category that grew nearly as quickly as the GDP, and we actually lost ground in areas such as environmental quality, time use, leisure, and culture activities. The report highlighted the need for more of these policies to balance the delivery of good health care. This October, by the way, we're going to be releasing the second National Composite Index, as well as provincial data, and I encourage you to contribute and to follow these results as well. So my fourth point is upstream care. And finally, transformative change. The final lesson, namely that governments must show the will and the leadership and the vision, an overused word, to achieve what is truly transformative change, not just to tinker around on the edges. How so? Modernizing and transforming the healthcare system involves the evolution of many things. I've identified some. Primary care, people's first point of contact. We've got to continue to break down the silos mentality, which separates GPs from other professionals and other professionals from other professionals, and a broad range of frontline illness, wellness, and diagnostic health services that are essential to preventing or mitigating downstream acute and institutional care. Simply stated, we need to break down these traditional barriers, which is very difficult to do, and reform the system, and it's going to require political leadership and professional leadership to achieve. Now, one approach would be, I think, to adopt a national strategy, underline the words here, national strategy for expanding community health centers across the country. I'm a strong believer in the community health concept and expanding them across the country with new federal dollars targeted specifically for that purpose. Another would be to finally implement a national home care strategy to relieve pressure on our hospitals and allow more Canadians to be treated at home rather than expensive hospital beds. There are other initiatives. But friends, what I'm getting at is that we need this kind of forward thinking if we are going to envision the future and translate the envisioning into practical results. Unfortunately, we have had a major setback in the last few weeks, as Armine has identified. And that is the government's announcement, Ottawa's announcement, that its transfers of health dollars to the provinces would be reduced. By itself, I don't object to that because there's still an increase. Maybe less money will be a motivator for more change. But to do so in the announcement unilaterally, Ottawa simply decreed it upon the provinces without any consultation or forewarning in advance, and simply said to them, in effect, goodbye and good luck. That is your money. Now think of Pearson, 50-50 with conditions. Think of Trudeau and the Canada Health Act, which is a condition, a national dimension to the program of health care. And so we have the provinces now on their own, and the Canada Health Act being totally sidelined. And we have essentially, if not 10 different experiments, certainly a variety of them, to which Ottawa, in denial of our national destiny and vision that I've talked about and values, apparently is oblivious to or doesn't care about. This illustrates a very serious loss of direction for Canadians, by our nationally elected government. It displays a federal government which, in my judgment, is unwilling to take a role for itself, as other governments have, in building this great program and keeping it viable, called Medicare. It is a purposeful decision to allow some provincial governments with their allies to surreptitiously move into the area of more private care, because, you know, we can't afford it, to offload from the public to the private. The same old arguments. We have to innovate, and other similar ideas. You're all familiar with them. To me, it looks like Ottawa is determined, well, it is determined to pursue this path. If it does so, Medicare's much-needed renewal will likely be thwarted. At best, we'll have a patchwork quilt. Perhaps even more importantly, Medicare might cease to be a unifying national force, valuable in its intrinsic purposes, valuable in its symbolic unifying features in a country which is very disparate and in some ways very fragile in keeping our unity together. Medicare would cease being that unifying national force, simply resulting, perhaps, painting the worst scenario, of a nation devolving into a patchwork quilt of various and competing provincial programs, and depending upon the financial strength of the provinces to top up or do the programs that they want compared to other provinces. This, to me, would be a great backward step to not only this great humanizing program, but a great backward step in the never-ending struggle to keep Canada united, unified, and committed to its shared destiny and its underlying values. So let me close, my friends. The Honorable Monique Bégin, who will be known to all of you, I would say fairly the author of the Canada Health Act, 1984, often reminds me when we talk about these issues that the true guardians of Medicare are, at the end of the day, the people of Canada. Today, an overwhelming majority of Canadians still believe in the vision, in the dream of Douglas and Lloyd and those people who worked with them to establish it. They believe in a vision of Medicare that sees this great program as a public good, not a private right, and as a defining feature of our Canadian citizenship. I believe that to be true. And if it's true, then today, more than ever, we need to reaffirm the original vision of a truly comprehensive public health care system, one that provides a continuum of services and includes a universal program of well-being, home care, long-term care, pharmacare, you name the reforms. Now more than ever, we need to embrace comprehensive policy solutions that tackle the root causes instead of the surface symptoms, that bring about systemic changes instead of quick fixes, that promote long-term benefits instead of short-lived gains. Now more than ever is the time to recapture the moral and political strength, like Douglas had and others in this room had, the moral and political strength to see ourselves in our own place, in our own time, informed by our own values, and within our own actual narrative which has shaped us as an independent nation called Canada, worthy of the respect of a world that needs even a better Canada and more Canadas. If we do this, and in doing this, we shall once again put our nation's policies on track and resume the great task of building an even greater, more humane and just Canada. On this 50th anniversary, and as you envision the future of Medicare, let us remember the sacrifices and contributions of people like Douglas, Lloyd, Pearson, Diefenbaker, Hall, Bégin, and all of those who could be named and should be named who actually made it work on the ground. And let us dare to make sure that it continues the dream for ourselves and for our future generations, the future generations that are depending upon us to do so. Good luck in your deliberations. Thank you very much for the invitation. See you again.